Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. First, I hope everyone had a nice Thanksgiving. I know I did, spending time with my daughter and her husband, and my husband, of course, in Arizona. So that was fun. We have, the holiday season coming up, but we also have a lot of things going on as year-end approaches. I know many of us are busy clearing that out, preparing for 2026 new codes, new regulations, the final rule. So a couple of things. I have a couple of webinars coming up that you may be interested in. I am presenting one with Stephanie Allard. We actually changed the date because we have some breaking news that we're told might be coming in, so we wanted to move it. So December 10th at noon Pacific time, 3 p.m. Eastern time, we have the Medicare Final Rule webinar, and you can find that on my website at terryfletcher.net. Also with McVeigh Seminars, I'm doing a Cardiology 2026 on December 9th at 1 p.m. Eastern, and then a Peripheral Vascular on December 11th at 1 p.m. Eastern. So take a look at that. Also, the fourth quarter Medicare updates that I do for two different companies, one for McVeigh Seminars and one for NSCHBC. NSCHBC is on the 16th at 11 a.m. Eastern Time. Look at that website, nschbc.org. And then McVeigh Webinars at mcveihseminars.com, and that's going to be the 17th at 1 p.m. Eastern. So take a look at all those. I have a very, very busy webinar schedule season in December, just catching up on all the last minute things. And we just want to make sure that we get everything out there for you. Hopefully you've ordered or received your CPT book. I know I have. And when I opened the cardiology section and then went to the peripheral vascular section, I was like, oh boy. So we have a lot to cover. So today I'm going to make this kind of a quick one because, again, it's year-end, month-end, and, month beginning, but I just got to get things going. And so I was looking at a lot of different things in my auditing services that I do, and I was doing an audit for a payer who was looking at the signatures and even the electronic signatures for the medical records, and they really wanted to take a lot of money and request a lot of money back to the providers because they weren't feeling that they didn't believe that the electronic signature really met the qualifications for the validity that signature did what it was supposed to do. So, basically the title here is that signature saying enough? So physician signatures, they're often treated as basically the final checkbox in the documentation. It's there or it's not. But, a lot of times the physician signature, it carries really the compliance risk beyond just, is it there? So according to Medicare, and they have this on their website in writing, a signature of the medical record serves as what they call an attestation, a legal statement of authorship, review, and responsibility. Let me repeat that. A signature on the medical record serves as an attestation, a legal statement of authorship, review, and responsibility. So it confirms that the services documented, were performed and medically necessary. But in the audits that I see, signatures fail to meet just a basic critical requirement that it's medically necessary. And a lot of times those signatures are automatically added on not by the physician, just by the function in the, EMR, EHR. I know some of you still may be on paper records, but let's start first with what CMS says. Now, because we are in electronic age, I find it interesting they still have on their website that it must be legible. Well, of course, okay. It must be dated, authenticated by the individual who provided and reviewed the service. It may be handwritten or authenticated electronically. It may not be stamped signature, except in rare documented disability cases. So, as an auditor, this is where we kind of have to look beyond is it present or is it missing? We have to look also at the intent behind the signature. And I was recently reading an article by NAMIS, and they were giving some of the same information. I thought it was interesting. Was it applied in real time? Was it applied right after the record or the encounter was completed by the physician? Does the signature demonstrate or validate that the provider actually did review and approve the documentation? And can that be tracked back through audit logs in the electronic health record? And these questions matter because CMS doesn't just require the name. It requires the signature be a meaningful evidence of accountability of what's in the record. And a lot of times when you see auto apply in EMR systems of the signature where it says electronically signed by Dr. Jones as part of the template, there's no date, there's no way to validate when or how the signature was applied, and it may not pass the CMS audit as far as the intent and showing it was done in real time and showing it was actually the documentation was actually reviewed and approved by the provider. Another risk, and this is compliance, is the timing of the signature. Medicare requires that documentation be signed promptly, ideally before billing occurs. Backdating or delaying a signature, especially after a claim denial or audit request, not only is that a red flag, that would be like, putting in an addendum or a correction after you get a request for additional documentation information or after you get requested for an audit. Now, CMS does allow for a signature attestation statement when the signature is missing, but they're clear this is not a routine or best practice, and this is used sparingly and only when documentation supports it. So when this is a rare occurrence, they'll allow it, but not to go back and say, okay, well, we're going to go ahead and just auto-sign everything. And I see this a lot of times when doctors leave practices, doctors, pass away from a practice and they're still billing under that provider. See how my voice got a little quieter there because I was like, yeah, that really happens, but I'm trying not to make it too loud because I was like, whoa. But I'm seeing that the signature is almost being taken for granted. So as auditors and coders, what is our response to this? We really have to shift from, the checklist of was it signed in auditing. That means we have to validate not just that the signature was there, but that it was applied with clear, verifiable intent, looking at the data, reviewing audit trails, ensuring compliance is embedded and not just in the documentation, but in the workflow and the culture. I review constantly split visits, meaning that there's a E&M and a preventative or an annual well on the same date. Well, I started really looking into this from, again, we talk about an auditing versus a coding perspective. You can always look at a coding perspective. Did the code or did the documentation suffice for the code today? Well, okay, yes. But then when you look at an auditing perspective, remember my podcast last week, behind, front, and after, I've noticed a lot of workflows have the patient coming in for what I call a sick appointment, an E&M, and then while they're there, as the patient is sick, they're like, let's go ahead and do an annual well. Let's go ahead and do a preventative. No. And then I see the timestamp that's taken place after the fact. Well, one of the requirements for having clinical staff that aren't physicians providing an annual well visit is that they've reviewed and that they have agreed with the documentation. Well, how can they do that if the patient already left the physician office or left the physician space for the E&M service and now is in the well check space and they're not well? So that doesn't make sense. And also that's against what CPT says about preventative. It says if an abnormality is found during a preventative, then you can bill an E&M. It doesn't work in reverse. But when I try to educate providers, this is part of your workflow and your processes. Signatures are not a technicality. They are a compliance marker and a critical one at that. We have to help our providers understand why we ask about the signature. And that reinforces it should be our shared goal. Accurate, timely, and defensible documentation. And remember, we're in the world of CDI, clinical documentation integrity. And just seeing the physician's signature isn't the end of the note. That's where we start our accountability. So make sure if you are auditing, whether it be internally, externally, you're going beyond just saying, oh, it's there, or it's just saying it's electronically signed. You need to make sure that that provider do spot checks, inquiry, query the administratives, query the clinical staff that's in charge, the back office staff that's in charge. Say, is the doctor really the one putting that in? Look within your system. If you've got Epic, they've got footprints where you can look that up and look at the timing of it. Make sure you know that when they say electronically signed by a physician, that it also means that it's before the billing occurs, it happened in real time, and it demonstrated that the provider actually reviewed and approved the documentation. Because more and more we're seeing that when the provider is trying to defend themselves, they're like, I don't remember signing that. Okay, that's a problem. And yes, as coders, as billers, as auditors, as administrators, you can get in trouble for that. So we don't want you to be held accountable for something that you were not aware that was also your responsibility. But this is a really big deal. So hopefully you'll take this back to your practice at your next staff meeting. Also, a little bonus thing, I saw something that was interesting and I didn't even realize it for this year. So the code, the G code, the HCPCS code, G0136. So remember, that used to be the social determinants of health that you can do the assessment. It's not a screening, once every 6 months, as long as the patient needs to have it. Let's say that they are lacking in food support, so you set up Meals on Wheels for them or whatever you need and whatever they need. And so it's something like that. But I didn't realize that January 1st, because I don't use that code a lot, I don't bill for it, they actually changed the definition of what that code is. In case you didn't know, it says administration of standardized evidence-based assessment of physical activity and nutrition, 5 to 15 minutes, not more often than every 6 months. That's different. So it says the service is not a screening for every patient. It's to be performed when there are known or suspected needs related to the patient's physical activity level and nutrition. Now, I saw a practice trying to report this. This is why I looked it up and went, wait a minute, let me go back and read this definition, because I hadn't seen it in a while. And they were trying to report this when the nurse practitioner would say a macro statement on every single medical record. It said patient should try some kind or some form of exercise daily. Well, some of these patients were wheelchair bound. They weren't able to do physical activity. And I was just like, okay, that's not an assessment. That's basically a smart phrase. So it says the service is payable when both physical activity and nutrition assessment are performed. So it says when either a physical activity or risk assessment is performed, if there is a clinical scenario where only one is reasonable and necessary. For example, if a beneficiary has recently started a new diabetic diet, but their physical activity levels have not been assessed, only a physical activity risk assessment may be reasonable and necessary, not this code. So you have to know that this is and, it's not or. So they were very specific with this. Also, they said this can be billed with a 90791 psychiatric diagnostic evaluation, any of the health behavior assessment codes. Now, can it be billed with the 90792 code? I haven't seen that yet. It doesn't list it as one of the base codes because, again, this is an add-on code, G0136. When performed on the day of an annual wellness, patients don't have to pay a copay on that. But remember, every 6 months, when performed on the day of a regular visit, which again, it does add on to an E&M, if it's medically necessary, they do have a deductible and copay there. And it's once per 6 months per practitioner per beneficiary. So really watch those definitions sometimes because they sneak up on us. When the administrator, when CMS says standardized evidence-based assessment, so they're not requiring a specific assessment tool, but they do give examples of those tools. And so make sure that you take a look at that. I believe that this may be done by auxiliary staff, definitely clinical staff, but how it's managed in the workflow and when it's done, after the practitioner assesses a need, you have to make sure the physician is the one that said this was important. Please don't add on codes. That's a weird thing to say. Just because you can. You have to say that this patient definitely needed this assessment. Evidence-based means there's a problem where, with exercise and or nutrition that this needs to be discussed. I would think diabetic patients, I would think patients who have obesity issues that are being addressed, patients that there's any kind of nutritional problem, any kind of, exercise issue. Let's say a patient's on a GLP-1 drug, but you don't just take the drugs and then eat whatever you want. You still have to deal with some, movement, exercise, etc. Well, this could be, a possibility of that discussion that you would get some extra reimbursement for if it's necessary for those patients. Now, in FQHCs or rural health clinics, you don't get additional reimbursement. It's not considered a qualifying visit in the FQHC, so there's no reimbursement for that. But just, keep this in mind, because I was just really surprised when I found it in the new fee schedule for 2026. And again, 2026. If I said 2025 before, I'm sorry. But in the CMS 2026 fee schedule final rule, 1832F. It's on page 459 to 465. This is what they talk about in there. But the January 1st, 2026, that code that used to be for social determinants of health has changed. So keep those things in mind. You always want to look at the narrative descriptions, because you never know when they'll change them, and they don't always let us know because it's not in the CPT book. It's HCPCS, so you have to go search it out and find it if it's something you're using. Okay, everyone. We are definitely into December, and I hope everyone, again, enjoyed their last month holiday. I hope everyone is getting ready and likes this fall weather. We had such a hot summer, so I'm excited about it. Finally get to put on some sweaters. But everyone, make it a great week, make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.